Hello everyone, welcome to YouTube live session of a recent guideline. Very important for the upcoming Part 3 exam as well, and also for the Part 2 students. Identification and management of maternal sepsis, Green Top Guideline 64. I'll just wait for a second so that you all can join, and then I'll start. Okay, so now when you all have joined, it's time to start our today's session. And of course, it's going to be a short and sweet session. And don't forget, stay till the end because we will be discussing a few questions from this new guideline as well. So let's start. Identification and management of maternal sepsis. So previously, we used to have two big guidelines. One was in the pregnancy and one was post-pregnancy. So very thankful to RCG that now they have summarized everything in one guideline. So that's a very good thing because at least the reading material is half. Further, 70% less we will do. That's my promise. So that's why it's going to be a short and sweet session and prepare the guideline in 70% less study time with us. So here we go with this session. So maternal sepsis. This is a life-threatening condition. So exactly what the definition is. Organ dysfunction which is caused by infection. Any dysfunction, organ dysfunction which has been caused by infection. So the primary cause is the infection which is leading to the organ dysfunction, and it is during the pregnancy or postpartum. If it is life-threatening, if not promptly recognized and treated. So the main theme of all of the guidelines is probably think sepsis. Think about sepsis so that you recognize it at the earliest and it can be treated at the earliest too. If you have any questions, you are welcome to write them in the live chat and I will be certainly happy to answer all your questions. Now, when do we say that it is septic shock? So persistent hypotension requiring vasopressors to maintain the mean arterial pressure of more than or equal to 65 millimeters of mercury. This is something same which we have been reading since in our Part 2 old guideline. That is the cutoff for the mean arterial pressure is 65 millimeters and mercury. What's new? Now look at the other sentence. Serum lactate greater than 2 despite fluid resuscitation indicates inadequate tissue perfusion. So now, if you remember, there is a recall question in the Part 2 exam. What is the level for the severe sepsis or the septic shock? I think there was always a confusion about 2 and 4. But here, now you see that it is the 2 which is the answer. So the correct answer to that recall question is 2, despite fluid resuscitation. So this is serum lactate more than 2. This goes in the favor of septic shock. So again, one confusion solved as we start moving further. Something about the epidemiology. Global and the UK statistics, 11% of the maternal deaths globally due to sepsis. UK mortality rate is 2.5 per 1 lakh maternities. And 2019 to 21 UK data suggests that 10% of maternal deaths were due to sepsis. Still a huge number and long way to go. And 14% is linked to COVID-19. So 14% deaths during this period were linked to COVID-19. Improvement is attributed to flu vaccination. There's a big role of the vaccination, particularly to the deaths which are related to the influenza and the COVID-19 vaccination, healthcare staff education, and guideline implementation. So flu vaccination, healthcare staff education, and guidelines were implemented, which has led to this improvement in the maternal death due to sepsis. Now, what are the next points? So how can we prevent the sepsis related death? What are the things where we can work over it? So what are the recommendations? Maintain high vigilance. Again, as I said, the first thing is think sepsis. So maintain high vigilance. You have to be quite vigilant about it. You should be thinking about it so that you can easily recognize. Ensure early diagnosis and prompt treatment. So early diagnosis and prompt treatment is certainly important. Broad spectrum IV antibiotics. In a moment, we will be talking about what antibiotics are recommended as in broad spectrum. Involvement of senior clinicians early. Specialist input. Now, in part 3 sessions, when you are going to answer the questions of the sepsis, don't forget to involve the infection specialist and the critical care team. These two are must for your MDTs, right? Specialist input, sorry, it's specially mentioned as a specialist input, the infection or the critical care team. So don't forget this point to add these two in your MDT scenarios. Vaccination promotion is essential in COVID-19 and influenza. So these are some of the points. I hope they are useful for your exam. What are the risk factors? Now, risk factors can be classified as antenatal, intrapartum, or postpartum. So antenatal ones can be like diabetes, obesity, anemia. So diabetes, anemia, immunosuppression, they can all lead to high chances of infection. History of invasive procedure, recent invasive procedure, already diagnosed case of GBS colonization or bacteriuria. What about the intrapartum ones? Intrapartum ones are the prolonged rupture of the membrane and the vaginal trauma, instrumentation, any indwelling catheter which is inserted, or even if multiple vaginal examinations. So it is very important that you follow the hourly schedule. What kind of a recommendation is there that should be followed? So these are the various intrapartum risk factors. In postpartum, cesarean section, retained product, wound infections, and of course, endometriosis is a very, very, very important one. So if you just put them in a one list, it becomes very difficult to remember. But if you can think about like preoperative means any medical condition will be preoperative, right? So diabetes, obesity, anemia, HIV, or any previous invasive procedure which has occurred, or GBS colonization or bacteriuria. So these will be there in the antenatal period. If I talk about the intrapartum, then what can happen in intrapartum, right? You do the vaginal examinations. So vaginal examinations is there. You can catheterize the patient so that way you can have a catheter in situ. Vaginal trauma instrumentation you can do in this phase, and the prolonged rupture of membranes can be there. Postpartum, it is the cesarean section, retained products can be there, wound infection, endometritis. So now I think if you just remember it as a breaking into different things, you will be able to remember them in the exam very easily. So no need to worry about the long chart. It's an easy way of learning which we can follow. Maternal sepsis, now what are the common organisms? Again, a very common part 2 question, right? Which is the most common organism for the maternal sepsis? Always has been a point of like confusion. So E. coli. Now it is clearly mentioned that E. coli is the one which is the most common and particularly when associated with the UTI, and this is common and treatable. In the guideline, one study of Ireland has also been mentioned from which a chart has been given which of the organisms, what was the percentage of the organisms which were which was extracted out in the culture. So that one was again showing the E. coli. So for now, for your exam answers, you can talk about the E. coli as the most common cause. But remember the highest virulence, or particularly if the patient is in the ICU, or if the patient is deteriorating, then your answer is gas. Gas in the mother. A adult, B for the baby. So A adult. So group A streptococcus, high virulence and leading to high mortality. So don't forget. So now if they ask you the question in the intensive care unit or a patient who is deteriorating fast, then the answer is group A streptococcus. But if otherwise the general question is asked, which is the most common organism, then you can choose the E. coli in that. Group B streptococcus is not for the mother, right? It is for the baby, right? B for baby and A for adults. Adults means mother. Coliforms, they can be linked to UTIs, P-PROM, cerclage, and important in the post-procedural cases. Anaerobes can be there, which is particularly along with the other ones, they are chorionitis, MRSA, and PDL producing Staph aureus. They are usually linked to the outbreak, and they can be included in the mastitis. Then other are like IGS, that is invasive GS, and the PDL, right? So first two lines, first three lines are the one which you need to remember, and that's the most important one. So that's about the common organisms which can be seen in the maternal sepsis. Now, I think I've answered few of your sepsis related recall questions commonly asked, right? Now it should be clear. What are the clinical features? Now this is important. This is important for the part 3 students as well, because with features, with these kinds of the features, you may have a structured discussion task this time because this is a recent update. So updated guidelines are very favorite of RCG for the part 3 exam. So fever or hypothermia. Now remember in this basically hypothermia is important as well, right? So it is a fever or hypothermia and tachycardia. So it is more than 100 beats per minute. Tachypnea is more than 20. Tachypnea is more than 21, and hypotension and confusion. Right? So fever or hypothermia. Again, it is very important to note that hypothermia is also a feature here. Tachycardia, that is more than 100 beats per minute. Tachypnea, more than 21 beats, 21 respirations per minute, and hypotension and confusion. Non-specific symptoms will be malaise, rigors, vomiting, pain, and pain will be out of proportion. So one keyword which RCOG often uses is, what often uses is the pain out of proportion. That is feeling the patient unwell. Patient is unwell. That's a very, very important point in these patients. So that's it. Now, coming to the next important thing here, that these are now they have divided this into the red flag features and the red flag features as well as the amber flag, right? Previously, there was no such categorization, but now it is the red flag and the amber flag, right? So we have to see what the difference is, right? So here it is the red flag features. So red flag features with suspected sepsis that indicate the high risk for sepsis. Red flag means they are high risk for the sepsis and they either require the immediate management or they immediately require the sepsis bundle to be initiated for inpatient and referral by blue light transfer from the community. So if the patient is in community and she has these red flag features, immediate blue light transfer, urgent transfers need to be done for these patients. And recommend the immediate management either with the initiation of the sepsis bundle for the inpatients. For inpatients, you will immediately shift on to the sepsis bundle. For the patient in the community, that needs to be immediately transferred to the hospital. Now, what all are the red flag features? If you look at the objective evidence of the altered mental state, then the GCS, general conscious state of the patient, is less than 15 and he is not alert, right? Not alert. Respiratory rate is more than or equal to 25 breaths per minute. Oxygen saturation goes below 94% on room air. Heart rate is 130 beats per minute, greater than 130 beats per minute. Blood pressure is systolic, less than 90 millimeters mercury. Urine output is not past urine in greater than 12 hours, or if catheterized, less than 0.5 ml per kg urine per hour. So at one stage, you are looking at the altered mental state. Respiratory rate has increased. Oxygen saturation has gone below 94% on room here. Heart rate is more than 130. Blood pressure is systolic is less than 90. Urine output not past urine in more than 24 hours if catheterized, and less than 0.5 ml per kg urine per hour. Now coming to what does the amber sign mean? So let's talk about the amber signs. Now, what we need to do in the amber sign, this is basically the moderate risk for sepsis. So these patients, you don't initially have to start with the sepsis 6 protocol, but it is basically for the senior clinical review within 1 hour for inpatients or as soon as possible in the community. So these patients, amber patients will require the review, while the reds will require the directly starting the sepsis protocol. Now, if we look at this, right, acute deterioration in the functional ability, that is the respiratory rate is 21 to 24 breaths per minute. Heart rate is 100 to 130 beats per minute or new dysarrhythmia. Systolic blood pressure is now coming down. Patient is going into hypotension. So 91 to 100 millimeters of mercury. Urine output is here same as it was in the previous one. So not past urine in last 12 hours or a catheterized then 0.5 to 1 ml. In the last we said less than 0.5 ml. So here it is 0.5 to 1 ml per kg urine per hour. And the patient had an invasive procedure in the last 6 birth, vaginal birth, management of miscarriage, any invasive, right? It will survival, in it. And there is the impaired temperature I 38. There is current diabetes or gestational diabetes is there. Close contact with any person who has the gas, that is group A streptococcus. And how will you come to know that? Whether it does the scarlet fever or the tonsillitis. Prolonged close contact with the case in a household type setting 7 for the onset of illness. Prolonged rupture of membranes, that for 8 to 24 hours. So now doctors, which is basically clinical review, senior clinical review within 1 hour in the patients who are inpatient and as soon as possible in the community. Features according to what site is affected, then this is the chart, right? It seems more cumbersome, but it is not. We already know that what kind of a signs can we expect in the we can expect in these patients who are having this kind of a problems, right? So here it is basically in head. When the meningitis is there or meningoencephalitis is there, then photophobia, neck stiffness, altered conscious level, delirium, focal neurological seizures. So these are clinical features because the brain is affected, the meninges are affected. So photophobia, neck stiffness, altered conscious level, delirium, focal neurological seizures are there. Ear, nose, throat, we know that is otitis, sinusitis, pharyngitis, laryngitis is there. Chest will have pneumonia, so cough with sputum, most likely bacterial. Patient may have hypoxia or the pruritic pain. Cardiac, it is the infective endocarditis. So there may be regurgitant murmur, embolic lesions, or hemorrhages. Hepatobiliary can be cholecystitis or cholangitis. So the typical right quadrant upper pain, Murphy sign positive. That is, if you put a pressure on the tip of ninth costal cartilage, patient will wince with a pain, right? So that's the Murphy sign positive for the cholecystitis. Upper abdomen pain, which is radiating to back. Now be careful for your part 3 candidate. You may have this kind of a presentation, patient presenting with these features, okay? Upper abdominal pain radiating to back. So don't miss this for MI, right? This could be a cholecystitis, which is or pancreatitis, which is presenting as the sepsis. So look for the signs of sepsis. Signs of MI will be totally different for the signs of sepsis, right? So be careful about that. Abdomen, you can have the gastroenteritis and appendicitis. So McBurney's sign for appendicitis is there. Atypical presentations are also more common. Bowel perforation more common in the inflammatory diseases. Breast mastitis can be there. So inflamed breast pain, features of sepsis and bruising suggest deeper infections such as necrotizing and enterocolitis. And finally, not the least, urinary tract is a very important. All cases of pyelonephritis require hospital admission, so they are very, very important. And finally, there could be a genital herpes also, which can present as a sepsis. So for the genital herpes, what would be your keyword is the acute urinary retention, right? Which will not occur in the pyelonephritis or the other UTI infection. Regional anesthetic blockade related infection, that is meningitis and spinal sepsis. This is important for your part 2 exams, right? Where they give you the scenario of cesarean where the epidural was given, or maybe the patient in labor analgesia where the epidural was given, and then she had the kind of signs of sepsis. So think about spinal abscess, right? Spinal abscess could be one of the possibility there. What all you can have is headache, photophobia, back pain, focal neurology, permanent spinal cord or caudate vena damage may result if the neural compression is not relieved urgently. Wound infection, as I talked about, the various wound infections can be there, cannula-related thrombophlebitis, wound infections per se. So skin and soft tissue infections are there. I could see a question in the live chat is about the most common organism for the SS site. Surgical site infection is still the Staphylococcus aureus, right? The most common organism for the surgical site infections is the Staphylococcus aureus, right? That you will not take as a E. coli. Soft tissue disorders, the superficial skin disorders are basically the Staphylococcus aureus, right? So I think that gives you the correct answer. And the most common organism for purpural sepsis is now going to be your E. coli because that's the one which is mentioned here, right? That's the one is mentioned in this guideline. So again, it will be basically the E. coli, but the most dangerous will be your gas, right? So remember, the most dangerous and the most invasive, which is more, the morbidity or the mortality is more with the propane cryptococcus, but the common organism is the E. coli, right? So I think I have answered both the questions which were there in the live chat. You can keep putting up your questions. As soon as I'll see the questions, I'll certainly answer in between. Now, this is the MEOWS chart, right? So, modified obstetric early warning score. This is the one which we have to use for the monitoring, right? So, this is the one which we have to use for monitoring. So, if you have seen the MEOWS chart, it also has the yellow. It also has the yellow, and it has the red, and it has the uh, amber, right? So, yellow, amber, and red. So basically, the red triggers the urgent review, and hourly monitoring is required, right? Hourly monitoring is required. What are the investigations which you need to see here? Within 1 hour of the diagnosis, within 1 hour of the diagnosis, you have to do the blood culture before antibiotics. Immediately, you have to take the blood cultures. I'll just talk about the sepsis 6 protocol where I will talk about what to give and what to take. It's very easy to remember, right? Three things you give and three things you take. So full blood count, CRP, urea electrolytes, LFTs, coagulation profile, lactate. Full blood count, CRP, urea electrolytes, LFTs, coagulation profile, and the lactates are the ones which are required. Urine, high vaginal swab. And imagine if source is not clear. We may require the X-rays, we may require the ultrasounds, or may require the specialized imaging, depending on what type of an infection we are expecting in this patient. This is septic bundle. So what I was telling you is take three and give three. Easy way of remembering this, right? Take three and give three. To be done within 1 hour, give three things, right? High flow oxygen you have to give IV fluid. Remember it is 20 ml per kg. 20 ml per kg is the dose which is required. So high flow oxygen, IV fluids 20 ml per kg, IV antibiotics are required. Take the blood culture, blood test, and monitor the urine output, right? So what you have to give is high flow oxygen, IV fluids, and IV antibiotics, and take the blood culture, blood test, and monitor the urine output. Now, these are the few things, these are the few indicators which help you define when you have to transfer the patient to the intensive care unit. So, indications for transfer to the intensive care unit. Just a minute, I can see the voice breaking. Is it breaking? Is it fine now? You can let me know. Is it working fine or not? Another question here is, I answered the postpartum sepsis. Yes, E. coli. SSI is Staphylococcus aureus. Which infection most common in postpartum, post-CS and VD? The same for all. It's the E. coli, but the serious infection is the gas group A streptococcus. Is the voice now clear or is it still breaking? Can you please let me know by writing your answer in the chat box? That would be quite helpful. Okay. Fine. Okay, so it's great that now it is fine, right? Okay, good now. Thank you. Thank you for letting me know. So I was talking about the indications for transfer to the intensive care unit. Now, if the hypotension is less than 90 millimeters of mercury systolic or the raised serum lactate. Now, see, 2 is the cutoff where patient will be in the septic shock, but 4 is the cutoff where she needs to be transferred to the intensive care unit, right? So it is the raised serum lactate persisting despite fluid resuscitation, suggesting the need for vasopressor or an inotropic support. Respiratory, it is pulmonary edema, need for mechanical ventilation, or need for airway protection. Renal is renal replacement therapy. Neurological is decreased conscious level, or miscellaneous multi-organ failure, uncorrected acidosis and hypothermia. Now for all Part 3 and Part 2 students as well, because Part 2 students may also have a question like this, which patient they give you such kind of a patient, and in the options they will give you the antibiotics and all this to be done and falana, and this, that, and they can give you one option of transfer to intensive care. Okay, so be careful. This could be a new option in your EMQ question. So transfer to intensive care unit. If you see any of these, instead of thinking about the medication, first think about the intensive care unit because you are not the one who's going to manage it. For my part 3 students, I would like to tell them that they may have these kind of picture in the scenario, or secondly, whenever they are having a sepsis patient in your structure discussion task, when immediately we tell them, okay, refer her to the intensive care unit. Be thoughtful. If the patient is not having these conditions, you will not transfer to the intensive care unit. Of course, you can transfer the patient to HBU, but not to the ICU, right? This is very important. You carefully use your words HDU or IQ. So the chart is important for both part 2 and part 3 students for looking for how to take into this. There's a question here. Sepsis is severe infection. So when will we say gas? No. Sepsis is severe, but the sepsis is basically, sepsis can be caused by the E. coli as well. But the problem is that when the patient is going to the ICU, right? When the patient is becoming severe, then it is basically the gas, right? The source of infection can be E. coli, but the severity will be with the gas. Patient getting transferred to the intensive care unit, right? That will be the scenario where the gas will be more common. Or patient deteriorating fast. The vitals are changing fast, right? So that patient will be having in a scenario of the group A streptococcus. Now, the antibiotic in the source control. What to do? So give antibiotics immediately. Do not delay for culture. So broad spectrum antibiotics need to be used. So broad spectrum antibiotics include what? Piperacillin, tazobactam, or what we need to give in these patients for this. So piperacillin, tazobactam, meropenem can be given and clindamycin combinations. Piperacillin, tazobactam, meropenem, clindamycin, they can be used for the broad spectrum antibiotics when we do not have any cultures, because we will not be waiting for cultures to start the antibiotics, right? So give antibiotics immediately. Do not delay for the culture. Tailor-made based on microbiology. Duration is 7 to 10 days and a control source evacuate RPOCs, drain or abscess, whatever is there. You have to go accordingly. Evacuate the RPOCs, drain the abscess. So tailor-made based on the microbiology. Now, because initially you do not know, so if the microbiologist is, I mean, till the date you get the culture, so you can start by this. Now, the role of various antibiotics. A simplified summary, as promised, totally simplified, right? So let's talk about this. So coamoxiclav. So basically, in the coamoxiclav, it is active against many gram-negative MSSA, streptococci, and anaerobes, but it is not effective against the MRSA or the pseudomonas. The risk of necrotizing enterocolitis in babies if used in utero. That's why we do not prefer using it in third trimester at least, right? Because the necrotizing enterocolitis risk is there. Metronidazole covers the anaerobes only, right? So covers the anaerobes only, that is metronidazole, often unnecessary if using other anaerobic cover antibiotics like piperacillin and trazobactam. So metronidazole is for only anaerobe. If you are already using the piperacillin trazobactam, then you do not use the metronidazole. So that's why when I told you about the broad spectrum antibiotics coverage, which need to give without any blood culture report. I didn't talk about the metronidazole because I have talked about the piperacillin tazobactam, and that already includes that kind of a coverage. So that's okay. Regarding the clindamycin, it covers the gas, MRSA, and anaerobes, no longer used for the GBS prophylaxis. Risk of Clostridium difficile superinfection, not renally excreted, not nephrotoxic. So this is not nephrotoxic. It can be given in the patient in which the renal parameters are decreased. Therefore, we have added the clindamycin as a baseline drug. So no longer used for the GBS prophylaxis, but can be used for the MRSA organisms. Piperacillin tazobactam. This is broad spectrum, gram-positive and gram-negative, including Pseudomonas. No activity against the MRSA or ESBL producing coliforms. Renal sparing. This is very important, but it has a poor CSF penetration. And important is if the patient is allergic to penicillin, then not to use this drug. Avoided in beta-lactam allergy. So it's a broad spectrum, gram-positive and gram-negative, no activity against the MRSA, renal sparing and poor CSF penetration, avoiding beta-lactam allergy. Cephalosporin ceftriaxone covers the GS and GBS, not enterococci, no MRSA or ESBL activity. Clostridium difficile is the risk, and it should be avoided in severe beta-lactam allergy. That means it can be used in mild or moderate beta-lactam allergy, right? But not in the severe forms. Carbapenem, very broad spectrum. Meropenem, right? Effective against most gram-negative and the enteroc. But here, see, it is not gram-positive. That is why we have to combine this to the piperacillin, tazobactam, and meropenem, right? So very broad spectrum, not active against the MRSA or the CPE, and not suitable for severe beta-lactam allergy. And it has excellent CSF penetration. So it can work in your brain conditions as well. Gentamicin, it covers the gram-negative, but remember this is nephrotoxic and ototoxic, so not to be used routinely. Only required when you are sure that the renal status is okay. No streptococcal or anaerobic cure is there, inactive in pus anaerobic environment. Vancomycin, this covers the MRSA used for GBS and penicillin allergy. So this is the drug which we need to use. So gram-negative activity requires the IV use, not absorbed orally. This is very important that vancomycin requires the IV use, right? And it has to be given over a period of 1 hour. So it takes time and it is IV over the period of 1 hour, not absorbed orally. But it can lead to the renal toxicity and the red band syndrome. Now, what is important is MDT, critical care, and the venous thromboembolism prophylaxis. Very, very important. Involve consultant, anesthetist, microbiologist early, and the critical care team if the patient is going into the ICU. ICU patient in shock, lactate more than 2, or in organ failure is there. Give low molecular weight heparin unless contraindicated. Prevention, hand hygiene, aseptic techniques to be used. Limit the vaginal examination. Early GBS screening to be done. Timely antibiotics for the procedure. So maintain the sepsis. Complete aseptic techniques to be maintained. Limit the vaginal examinations. Early GBS screening to be avoided. And timely antibiotics for the procedures to be given. So this is how the prevention works. And of course, the prevention is always better than cure. That is why RCVG says think sepsis. Now, these are few tips. These are few tips which you need to remember. Spot MEOWS red triggers, right? Whenever your MEOWS chart, especially if your part 3 exam, where they put up long sheets and there is a MEOWS chart as well. And then you start searching, oh my God, what I have to read and what I don't have to read. At least what you can look at a glance is if any of the red trigger is there, if anything goes into the red, that is sepsis, and you have to start the sepsis 6 protocol, right? So if any one thing which you find in the red, no need to go into the depths of that particular MEOWS chart. If any one thing goes red, you have to get a trigger for the sepsis 6 protocol. You should be able to differentiate between the systemic inflammatory response and the sepsis. Of course, we are looking for the lactate levels in that, hypotension is that, so that all features we are going to look at. Suspect gas and rapid deterioration. I think this was the question which was asked to me that sepsis itself is a severe, so how can we answer the gas? So gas to be answered if there is a rapid deterioration, right? So repeated presentation to the general practitioner or community midwife or repeated self-referral to the obstetric triage or day assessment unit should be considered a red flag and warrants a thorough clinical assessment to investigate for signs of sepsis. Now, be very careful, part 3 candidate, because till date, repeated presentation was taken as a red flag for domestic violence, right? You always took this repeated presentation to the GP, to the midwife as a red flag for the domestic violence. But remember now, this is a new red flag, very upcoming, prominent thing which can come in exam. So this is a new red flag for the sepsis. That's why I've highlighted this point because you need to take care of this point. And early MDT involvement is the key. Now, what are the common points, common MR, COG, SPA triggers, right? Questions which can bring in the further questions, the points which can bring in the questions. A postpartum woman with a fever, tachycardia, and the foul discharge. Think endometritis. Postpartum women with fever, tachycardia, and the false running discharge. Think about the endocarditis. Endometritis. Sorry, it's not endocarditis. We are talking about the genital tract, of course. So, endometritis. Post-cesarean collapse, hypotension, and rigors. Post-cesarean collapse, patient collapses, rigors is there, specifically rigors, unwell patient, rigors. This is wound infection. Think about the wound infection. Okay, MEOWS showing red triggers needs urgent senior review. Okay, these are the trigger points. These are the keywords which you can have in your exam. So be very careful of this. Key points are important both for part 2 and part 3 students. Okay, so I have 10 questions before I finish this session. And yes, while you are all ready to answer, I'll be looking for your answers in the chat. So just keep answering. 28-year-old woman presents 2 days postpartum with fever, 38.8 degrees centigrade, rigors, and offensive lochia. Now her MEOWS chart shows a red trigger. What is the most appropriate next step? A 28-year-old woman presents 2 days postpartum with the fever, rigors and offensive lochia. Her MEOWS chart shows a red trigger. What is the most important next step? Yes, is it prescribe oral antibiotic? Is it arrange the pelvic ultrasound in 48 hours? Start IV antibiotics and perform sepsis 6 within the 1 hour. Observe for 6 hours and regular vitals and request senior review within 24 hours. Yes, C is the correct answer. Why E is not the correct answer? Because immediate senior review is needed, right? And here they are giving us review within 24 hours. So C is the correct answer. You have to start the early management with sepsis 6 within 1 hour. Very good. Everybody answered right? Great. A 35-year-old woman develops a fever and a hypotension following a cesarean section. You suspect sepsis. What organism is most commonly associated with rapid deterioration in postpartum sepsis? 35-year-old woman develops a fever and hypotension following a cesarean section. You suspect sepsis. Which organism is most likely associated with the rapid deterioration in postpartum sepsis? Yes, the rapid deterioration is particularly the group A streptococcus, right, is known for causing the rapid deterioration and the toxic shock in postpartum women. Very good. Oh, it's such a, I'm so much satisfied that everybody has heard it very clearly and got the message right. Thank you so much. Which of the following is not included in the sepsis 6 bundle? Which of the following is not included in the sepsis 6 bundle? Administer the high flow oxygen, give IV fluid, prescribe thromboprophylaxis, take blood cultures, and monitor urine output. Administer the high flow oxygen, give IV fluid, prescribe thromboprophylaxis, take blood cultures, and monitor the urine output. Following is not included in the sepsis 6 bundle, which is not included. Which is not included. Great. It is the option C. Correct. So option C is absolutely correct. Thromboprophylaxis is the important part, but that is not the part of the initial sepsis 6 bundle. A woman presents with the signs of maternal sepsis. A woman presents with signs of maternal sepsis. Her lactate is 3.5 despite fluid resuscitation and she remains hypotensive. What is the next best step? What is the next best step for this patient? She is lactate 3.5 despite fluid resuscitation and she remains hypotensive. What is the next best step? So she needs escalation to the critical care. So that is what she needs. She needs escalation to the critical care. D will be the correct answer. Which of the following is the most important predictor of poor outcome in maternal sepsis? Which has the which is the predictor of poor outcome in maternal sepsis? Presence of fever, anemia in pregnancy, delay in antibiotic administration, raised vital count, or multiparity. So, which one is the basically the most important predictor of poor outcome in the maternal sepsis? Yes, it is the delay in the antibiotic administration that leads to worse outcomes. So we have to give antibiotics appropriately within the first hour, and as we start, therefore, it is an important component of sepsis burden. Which of the following is true? Which of the following is true regarding the modified obstetric early warning score? It is only used in the postpartum period. Red triggers indicate the MEOWS should be discontinued. It should be recorded every 6 hours. Red triggers prompt urgent senior review, and it includes the fetal heart rate monitoring. So, what is basically the which one is true regarding the MEOWS? So that is the D. Red triggers in the MEOs require urgent clinical review and escalation. So that's the correct answer. Very good. Very good. I'm so happy to see everyone answering right. Okay, so everyone got the guideline right. Now you don't have to go through big guideline, right? You are good to go for your exam. A woman 3 days postpartum has ongoing fever and right iliac fossa pain. What investigation is most appropriate to detect the retained products of conception? Which investigation we can do, which is the most appropriate to detect the retained products of conception? So that's the transvaginal ultrasound scan. Good. So that's the transvaginal ultrasound scan. Now, what is the recommended initial fluid resuscitation dose in maternal sepsis? What is the initial recommended initial fluid resuscitation dose in maternal sepsis? Okay, so what is the recommended initial fluid resuscitation dose in maternal sepsis? Is it 5 ml? It is 10 ml? It is 15 ml? It is 20 ml? Or it is 30 ml per kg? So, which is the one which is basically yes. D is the correct. It is 20 ml per kg. IV fluid, that's the correct answer. Which of the following antibiotic practices is correct in maternal sepsis? Wait for cultures before starting antibiotics. Use oral antibiotics with mild symptoms. Delay antibiotics until imaging is complete. Start broad spectrum IV antibiotics immediately. Continue antibiotics only if cultures are positive. So start broad spectrum IV antibiotics immediately. Yes, that's correct. No, this is from the new guideline only, right? It still holds true with 20 ml. Which of the following is the most appropriate to reduce the guidance or incidence of the purpural sepsis? Which of the following is the most appropriate to reduce the incidence of purpural sepsis? Yes. So it is universal GPS treatment in all pregnancies, routine antibiotics for all vaginal deliveries, aseptic technique during vaginal examination. So yes, correct. C is the correct answer. Aseptic aseptic technique during the vaginal examination is one of the preventive measures. That finishes today's session, and all our dreams come true if we have a passion to pursue them. So if you have been thinking for a long time, doesn't know how to start, how to go ahead, particularly when you think that you are too busy to take up MRCOG, but MRCOG has been your dream. So, and you want to prepare in 70% less study time, like we covered our guideline right now, in 70% less study time. So, if you want to go ahead with that, then mrcogcourses.com. Click on this and be with us to pursue your dreams. And we are here to make it perfect in one go. So all your dreams come true if we have the courage to pursue them. And all the best for all part 3 candidates, all my part 3 candidates. I can see them well in their answering in the chat box, even the questions, right, which are not going to come the, for them, like they are answering the ABCD. They are not going to get that in exam, but thank you so much for joining, and you will definitely be benefited from the points we have discussed in this guideline. Thank you everyone for joining today, and be with us and join mfugcourses.com to prepare in 70% less study time. Of course, everybody wants that, right? So do a smart study, and see you all in the next YouTube live session.